the recording afterwards. Today's webinar is entitled The Role of Pharmacists in Digestive Wellness, an overview, and it's the first of a series of 4 events that focus on digestive wellness. The moderator for this event was supposed to be Dr. Saladin Griffin, but unfortunately, unforeseen health circumstances with their children, she could not attend. We wish you the best recoveries. And on her behalf, I will be moderating this session. My name is Ruben Viegas, and I'm the FIP Practice Development Coordinator. And I'm part of the FIP staff, and I work on the area of pharmacy practice, which is where this where this area of digestive wellness fits on the thousands of patients that in the pharmacies that come to us with digestive health issues. Just a few announcements before we go to the webinar. This webinar is being recorded and live streamed via YouTube. You can watch the recording and also the events, the next ones, on events.fip.org. Please, if you have any questions, use the Q&A, the question box provided. You can use the chat to greet each other and also to tell us from where you're hearing and listening to this webinar. Any feedback, you can provide it to webinars@fip.org. And if you're still not, you can join FIP at fip.org membership registration. FIP would like to thank Sanofi Consumer Healthcare for supporting this online event through unrestricted funds. So today we have a fantastic panel with 3 panelists, Anna Sinclair Jones, Mara Corset, Harnett, that will guide us through different topics and give us an overview of the aspects of digestive wellness, as well as how the pharmacists can support practice. So as I was saying, you will have the 3 presentations. First, an overview of the pharmacist's contributions to improve digestive health. Then we'll hear a bit about chronic and temporary constipation, and also a bit on the use of laxatives. And in the end, we'll hear a bit more about the tips for pharmacists on prevention advice to improve digestive wellness. At the end, we'll have time for questions and answers. So please, if you have any questions during the presentations, please write them down in the Q&A. So the learning objectives for this session are that participants should understand the role of pharmacists in providing advice on digestive wellness, understand the relationship between gut wellness and immunity, and identify ways to support better digestive wellness in the community. Just another, yesterday was the World Digestive Health Day. This is an initiative from the World Gastroenterology Organization. And the topic for this year is the colorectal cancer prevention. If you want and you're interested, you can check more about this campaign on their website. So without further ado, I'll just introduce the first panelist, which is Eris Sinclair Jones. She's qualified as a pharmacist in Switzerland in 1987 and has since practiced as a clinical pharmacist in the United Kingdom. In 2011, Anya completed an MSc in Advanced Pharmacy at University College London, whilst leading the surgical team at the Brighton and Sussex University Hospital NHS Trust. National and international publications show clinical care in the gastroenterology field and encourage and inspire young pharmacists to strive for the excellence in pharmacy practice. Thank you, Anya, for showing us pharmacists' contribution to improve digestive health, and the floor is yours.
Thank you very much, and good morning, and thank you for asking me to talk. Could I have the next slide, please? I'm a consultant pharmacist in gastroenterology, and I've been involved in gastroenterology probably since 2000, when I was looking after a surgical ward, and it was joined up with the gastroenterology service, and all of a sudden I had to learn all about medications, and particularly when the biologics came in. So I'd just like you to tell a little bit about what I'm doing, but also how we can get to expert pharmacists' roles in digestive wellness. Please, next slide. I have no relevant disclosures. Next slide. So what's really important is that any pharmacy practice is embedded in the pharmacy service. The pharmacy service is embedded in the multidisciplinary team. And that affects any practice, the community, even regulation industry. We cannot work alone. We have to work as part of the healthcare system. And next slide, please. What's really important for gastro is that we know exactly where the gut is. And for this, we need to be able to speak the same language as the multidisciplinary team. And therefore, Ruben, if you just slowly go through, we just talk about what the medics call, how they use the different parts, how they talk about the different parts of the gut. And for me, it's the stomach, then comes the duodenum, jejunum, ileum. And with the terminal ileum in gastroenterology, it's often called TI. And with the TI, and that's where Crohn's disease mainly is. So you've got then the cecum, and then the colon has three parts. You have got the ascending, the right-sided, the proximal. This is all the same part, and they will use it all interchangeable. You've got the transverse colon, then the descending left-sided or distal, and then you end up with the sigmoid. So it's really important when you read an endoscopy report, for instance, so you know what is meant when they say they get to the TI or they only manage to get to the hepatic flexure. So, so we speak the same language. Next slide. So and the other thing is you need to know the GI organs and how they work. So you've got the liver, you've got the common bile duct, which enters into the pancreatic duct to then go into duodenum. That's really important because when you have an ERCP, it goes through the stomach, into the duodenum, through the pancreatic duct, into the common duct. So that's understanding how endoscopy works. And if you have time, join an endoscopist on his list. They're showmen, they love showing off, and you understand what they're doing. Next slide. So it's really important we understand the anatomy and the physiology. And I then thought, what conditions are GI conditions? So we have a whole range of them, of course, the dyspepsia, GI bleeds, diarrhea, constipation, nutrition, and GI cancer. Considering it's colorectal cancer day yesterday, the GI is really important that we keep it as healthy as possible. We've then got the hepatobiliary diseases, which is still part of gastrointestinal. So we've got the liver disease, biliary disease, and don't forget pancreatic diseases, and all of them obviously have cancer problems. Can you just go back, please? Just what's probably the next big thing for GI is going to be metabolic syndrome, our overweight patients who will present themselves with NAFLD or NASH, which is non-alcoholic fatty liver disease or non-alcoholic steatosis hepatitis. This is going to be a big issue where we will have to work in the multidisciplinary team together with the cardiologists, together with the endocrinologists to manage these patients holistically. And this includes, all the nurses, all the dietitians. Diseases are now so complicated that we need to work as a multidisciplinary team. And we have, sorry, I just had the message, which so the multidisciplinary team, and the treatments and the medications are becoming much more complicated, and we are the lead in medication. We're the lead in pharmacy. We really need to be part of the multidisciplinary team. Next slide. So I thought also what you're going to bring to the multidisciplinary team is how the medications are affected by the GI diseases. So think about ADME. And then, of course, how the medication affects the GI system. So think about which medication causes constipation, particularly in alcoholic liver disease. This is a real problem. Think about diarrhea, ulcerations, which medication cause ulcerations. Could that be the cause of why they come to see you? Gallstones, liver disease. And then also think about surgery. If you have bariatric surgery, which medication isn't absorbed in this, isn't because of we bypass the stomach. So it's a really complicated, but we are the specialists, and we know, or should be known, where medications are absorbed, how they affect the GI system, and how the GI system affects the absorption or the metabolism. So it's a really complicated system, but once you think about it, it's very logical. So next, please. So the other things you need to know, particularly when you're in a frontline service like the chemists or the primary care, think about the red flags. When do I have to refer? You know, rectal bleeding for a while, anemia, losing weight. Could it all be cancer? Could it be more serious diseases like inflammatory bowel disease? And you don't need to know it all, but you need to know who to ask and when to refer. Next, please. So I just thought, which are the most common areas which we need to really think about, which are including our minor illnesses, which we can happily treat in community, which is dyspepsia, constipation, diarrhea. Think about infected diarrhea, think about antimicrobial stewardship. Most diarrheas won't need antibiotics. They can just be treated by good substitution of oral replacement therapy. IBS, you know, again, you've got diarrhea, you've got constipation. Think about which medication would hopefully help them. And then IBD, which of course needs to be referred. And again, that's where the red flags come in. Think about liver disease. As I said, obesity, metabolic syndrome is going to be our next big challenge. And probably viral hepatitis. We had a real good success with hepatitis C eradication in the UK. The next big hepatitis will be hepatitis B and hepatitis D, because there are really complicated drugs going to come in. They're going to be quadruple therapies, just like for hep C. And you are the specialist. You are going to know most about it. Next, please. Oh, actually, can I just go back? And there's this wonderful handbook, which I think, Ruben, you looked at this. There's this handbook for pharmacists, and in there is a whole section on GI, which is really worth looking at. Next. So I just thought I'd quickly tell you what I do as a highly specialist pharmacist in secondary care. Next. The first thing is it's a model of totally integrated care into the MDT. We are always there every week at the multidisciplinary team meeting. We join ward rounds, we run our own clinics. And when I first started, it was really interesting. We make sure that all the tests, which for particularly sort of therapeutic drug monitoring tests, are getting followed up because they weren't. We are optimizing the therapies, we're standardizing decision-making, and we are part of the regular patient review. And we also made sure that because they needed to increase their audit results, we were part of this process. And what's the most interesting thing is it then increased the focus of the medics and the nurses on pharmacoeconomics, finance, and optimization of drugs. Whereas as pharmacists, because we were much more involved in patient care, we all of a sudden started more concentrating also on quality patient care. Next. We run our patient clinics. I've now got a team of 3 pharmacists, but that was the first one. In the first 3 months, we saw 138 patients, which we optimized the medication. It's all immunosuppressants or immunomodulating therapies, and it started off with IBD, but now we're actually also looking at all the liver patients who are on transplant or autoimmune immunomodulator therapies. And we have we're doing all the drug monitoring. So we built up a whole service around managing and optimizing immunomodulating therapies, plus any other things that come along, like rectal sucralfate, all these weird little bits which we are specialists for. Next. And I've started sitting into the Infusion Clinic, where we help manage the Infusion Clinic. We were very involved. We led the biosimilar switch, which we then also audited. We do a lot of minor ailment addressing. So if a patient comes into the infusion clinic and has got some skin eruptions or something, we often help them support that, because if you are on an immunosuppressant, you're slightly more likely to get infection. So we manage this. And it's a very flexible service. We work very, very closely with the nurses who are in the infusion clinic. So it's a really multidisciplinary, holistic clinic where we manage the patients. We change the dosage if we need to. We adjust it. We optimize it. Next. As I said, we run the therapeutic drug monitoring clinic for thiopurines and biologics. So we do TDM and thiaguanine, and if anybody's interested, we shunt the thiopurines with allopurinol, which is very much involved around using interactions to optimize the medications, and there's lots of literature around it. And we adjust and manage the biologics. Because we're independent prescribers, we will look at blood levels, antibodies, anything that needs monitoring around it. So it's a really holistic service. Next. And we work very closely with the nurse. We now have our own helpline, but in the beginning, we were very involved in the nursing helpline, and we answered a lot of the medication-related questions, which is really good. And we also deputized for the nurse. And she was very pleased that she could pass on the medication questions to us. So that was a really good service to work. And we now manage actually our own helpline for patients to just email straight into us. Next. And the last thing, after the success of this service, we then employed a pharmacy technician who's absolutely integral to the service. She does a lot of the drug monitoring, and she has, next, we now have a blood monitoring accreditation package for this, for pharmacy technicians, which we use, because they can be they're highly skilled and they're really good at supporting the pharmacy service. Next. So that's what we do in our clinic, and how can we support our patients? You know, as I said, understand the conditions, make sure you attend the multidisciplinary meeting, you become accustomed, and it can be very scary because you're the only pharmacist. There will be lots of nurses, there will be lots of medics, there might be several dietitians, but it's always usually only one pharmacist. Go to conferences, specialist conferences, medic conferences, to get the knowledge, master classes, anything, you know, and become an expert in your area. And if it's a community pharmacy, think a general practice, you can be an advanced general practitioner. You know, we are the pharmacists, you are the expert medication leads, use your pharmacodynamic and pharmacokinetic knowledge. They will be amazed how much you can change and optimize the medication through our training. As I said, work with the multidisciplinary team. They are the best allies. If you provide service to them, they will promote your role. It's becoming so complicated, the medication treatment. They are really pleased that you have a specialist there. And also think a bit about your own CPD, your career. Where do you want to go? Join professional bodies like the FIP. Next. So how can we get to have a workforce that will be ready for the challenges of the medication therapies that are coming? And the WHO had their workforce plan in 2030, and the FIP came out with their own workforce development goal, and we need to make sure that we are optimizing our workforce. There won't be enough nurses, there won't be enough doctors, and there probably won't be enough pharmacists, but we are able to take some of the roles on, and that's what we need to get people ready for. And we need to invest in the profession and make sure they're ready. And we need to make sure the infusion are ready. So how do we get there? We need to, I think it's a behavior change. So you need to make sure the capability is there. Next, the motivation is there, and the opportunities. So we need to make sure there's good education, clear pathways to get to advanced practice. We need to make sure there's the motivation to do it. We need professional and financial recognition. And then we need to provide the opportunities, which means commissioning services. And that will advanced pharmacy practice. Next. And again, next again. So the FIP has the Advanced and Specialist Pharmacy Global Report, and they look at how can we develop it. So you start off right in the left-hand bottom corner, and you start developing your expertise. And on the right-hand top corner, you have the specialist roles like mine, very highly specialized. We don't need many of them. We need some, but many. But what we really need is a lot of advanced general practitioners. This is the most important challenge, that we get all our community pharmacists, GP pharmacists, hospital pharmacists to a really advanced level. Next. And for this, we need, as we said, profession recognition and credentialing. Now in the UK, we have the Royal Pharmaceutical Society, who's got the credentialing process. We're just changing it, but it's slowly happening. It's all based on 5 or 6 clusters. And the FIP has a similar global vision on education workforce, where they look at this. Next, there's one more. And how we get to the development goals. They are really clear. They're very effective. So if you're involved in training pharmacists, look at them. And next in between. And these are the professional development goals. They're very clear. We need to educate patients. We need to have access for them to be able to look at their career where we want to go. And there need to be strategies and programs in place to do that. Next. So in the UK, we were very lucky. In IBD, I was involved in setting the UK IBD standards. So standards for a service are very good, and that can be for any service. And really the goal of any service should be to have the best possible outcome for patients from their treatment and care. And that's, if you look at what that involves, it's exactly what the pharmacy profession should be doing. Monitoring and reporting, political agenda. We need to make sure we're on there when decisions are made, share good practice, and make sure quality is always embedded in services. And then we can't just embed quality. We need to know what quality is, and that's where standards come in. Define quality. What does good looks like? What does excellent looks like? Next. So with the MDT, I managed to get pharmacists now mandated as part of the multidisciplinary team. So all the 192 services in the UK now have to have a pharmacy expert in IBD. Beforehand, it was just a named pharmacist. Now it's very clear how much they have to do. Next. And we had to also define what does an expert pharmacist mean. And we based it on the faculty. We now have to adjust it to obviously the credentialing the RPS does. But it's very clear. So we made it clear what kind of level we want an expert pharmacist to be. We want him advanced. And we also have now got the tools to get them there to help them when we're developing a training program for this specialist. But that can be next. That can be done in any specialty. So we've got the ability, we've got the motivation, and we've got the opportunity. Next. As we said, the FIP has a really good framework for you to get there. Next. So we can develop expert pharmacists to support our patients in digestive wellness. We need to enable this behavior change. We have the capability, the motivation, and the opportunity. And as I said, even if you don't work in GI, this roadmap can be just used for any service in any specialty and also in any setting. We need just to make sure that the systems are in place, the opportunities are created, and also that we recognize what's good, best practice. Next. I hope that was interesting, and I hand over to Mauro. Thank you.
Thank you very much, Anya. Before we go to Dr. Mauro, just very interesting to understand first the practical aspect, because from my experience in community pharmacy, I came to the pharmacy with either recurrent dyspepsia, either is through nutrition problems or medication problems. So there's clearly a need for pharmacists to work on this area. And then also this aspect of the and the frameworks, which is also important both for the individual pharmacy to set goals, but also for the pharmacy associations and organizations to move forward and to understand the needs in this specific area of gastroenterology. So I'll come back to you closer to the end with some questions from some notes I have. But as you said, we will move and we'll move to the next presentation. I'll present Dr. Mara leads the GI Motility Service, and she's a referral consultant for functional disorders of upper and lower GI tract at the Nottingham Digestive Disease Center. In her specialization in 2000 and PhD 2004 in Italy, where she worked for 8 years as referral consultant for functional bowel disorders and lead of the motility unit of one of the most important university hospitals in Milan, the San Raffaele University Hospital. She then moved to Belgium, where she spent part of her PhD to work in the lab of Prof. John Track as senior research supervisor. So Maura will speak to us a bit about chronic and temporary constipation and what is the current evidence of the different uses of laxatives. Thank you very much, Dr. Maura, and the floor is yours.
Thank you. Thank you for this invitation. And I have to say, well, I'm a clinician, so not a pharmacist. And I'm quite happy to be here today, because I think that there's not so much interaction between clinician and pharmacist, and this should change. I think that the previous lecture was really interesting also for me, because it's explained very well how this kind of work between pharmacists and clinician can really be integrated. And I think that in UK is one of the best examples where this can be found. So I have been requested to speak about chronic and temporary constipation, and in particular about the evidence of what we can do for this patient. Next slide, please. These are my disclosure for this lecture. Next slide. So you can think, well, why we need to speak about constipation? Who cares? You take a laxative and everything is sorted. Well, if you look at this slide, this is a report that was reported in 2019. It is a kind of picture of how much is costing constipation in UK. In this case was in the period between 2017 and 2018. And you can say that it's quite expensive, both as a burden for the GP. You can see here that on average, a GP sees 6 patients with constipation per week. But what was really kind of concerning all of us when we saw this report is the number of admissions that we have every year, and they are not really planned admission for constipation, but are really admission where the patients are admitted because they cannot really sort the problem at home. And so this is particularly interesting, and is also the cost, the total cost of constipation, as you can see here. So this means that this is a problem, even if it's not considered really with the appropriate importance that we should give to this kind of condition. Next slide. So let's start reminding ourselves when we define a patient with chronic constipation. We have 2 possibilities. We have a patient that presents with the typical symptoms of constipation, and then the patient normally has straining, hard stool, sensation of incomplete evacuation, sensation of anorectal blockage. They can use to digitate to facilitate the expulsion of the feces, or they can have infrequent bowel movement. If the patient presents according to our international definition, with 2 or more of these symptoms, then the patient, and if the symptoms are lasting more than 6 months, we are defining this as chronic constipation. But in clinical practice, let's say that if the patient presents with these symptoms that are lasting more than 8 weeks, of course, we are already considering the patient with functional constipation. The problem is that the patient can present just with these symptoms or with these symptoms associated with abdominal pain. So if the patient reports also abdominal pain, and if you ask to the patient, okay, if you open the bowel or you pass some gas, or when you are more constipated, is the moment where you have more pain, this is a patient that have also what we call irritable bowel syndrome with constipation. And the situation is important to recognize this difference because the treatment approach to this patient is a little bit different, and in particular it can be different the response to the medication that we propose to this patient. Next slide. Recently, because I noticed that there was no really a good pathway to really guide the clinician, but also the pharmacist to really understand how to decide and select a different treatment for this patient, with some international colleagues, we developed this kind of guidelines. And this is the panel B that really is about how to interview the patient and really how to decide whether the patient has only constipation or is also in IBS with constipation. You can see here that the key question is really to start with understanding what kind of constipation the patient refers. So what do you mean for constipation? Do you have infrequent bowel movement, or do you have difficult to pass the feces, or both of them? And how many bowel movement do you have per week or per month? And really ask the patient also to report on the Bristol stool chart that is reporting the different consistency of the stools, to have an idea whether indeed the patient had hard stools or other kind of stool consistency. Then you need to ask whether there is pain or not, because these move in two different directions. And in both the cases, we normally start suggesting some lifestyle modification, and I think that the next speaker will go in more details into this, what is really an healthy diet and what represents a really good approach for our bowel. But if this doesn't work, the next step is normally in our clinical practice is to go, according to the evidence, to some osmotic laxative. Here I listed PEG or Macrogol, that is the one that has been demonstrated to be more effective than placebo in treating patients with chronic constipation. And this is the first line treatment that we can propose to our patient. If this doesn't work, you can decide to combine or switch to stimulant laxative. And here I listed the bisacodyl, picosulfate, but there is also senna. We have recent data that are also demonstrating that all these drugs are more effective than placebo in treating chronic constipation. And of course, these are normally the laxative that we have the evidence that they are working in chronic constipation. If this doesn't work, then you have the possibility to, but in this case, you need to have the prescription of the clinician to prescribe prucalopride, that is a prokinetic, is not a laxative, so is a 5-HT4 agonist that improves the motility of the entire gut. And this has been demonstrated to be more effective than placebo in treating patients with constipation, but has not been tested in patients with irritable bowel syndrome and constipation. So this is something that you need to take in mind. Or linaclotide, that is a secretagogue that improves constipation both in patients with functional constipation and with irritable bowel syndrome with constipation, even though at two different dosage. And unfortunately, in Europe, we have only the 290 microgram that sometimes can trigger some diarrhea that is difficult to control in some patients. Very important is this note that I put here in this side, is always to consider when you prescribe something or when the patient is taking any of this medication, then you need to assess how the patient is responding to this medication, but be sure that you are asking the right question, because if you are prescribing a laxative, this is to treat constipation. But if the patient has also abdominal pain, this is not going to improve the abdominal pain or cannot improve abdominal pain. And in this case, you need to consider whether it is important to combine this with a medication that target the pain. So very important to always ask the question and really assess and be sure that the patient understands why you are prescribing a medication, what is the mechanism that this medication work with, so that he can really wait for the right response and not pretend to treat something that this medication cannot treat. And this is okay, the evidence are this is the guideline that we prepare, but we know that all these medications are working more than placebo in treating chronic constipation. But is the mechanism the same? I have to say that before doing a study myself, I was kind of thinking that, for example, the stimulant laxative had the same mechanism of a medication like prucalopride, that is a prokinetic. But with great surprise, when I did a study with the Eris solution manometer when I was in Belgium, I found out that actually the mechanism of action of this medication on the colonic activity is quite different, and this was something that was unexpected. Next slide. So when I administered my healthy subjects the Pegor, Macrogol or linaclotide at the same dosage that we use in clinical practice, and I studied the response of the colon with the colonic manometry, the high resolution manometry. This is a tracing here of this recording. You can see that we are able to measure the colonic motility from the right colon until the anorectal, the anal sphincter. And this kind of activity that you see in green are the so-called long propagating contraction that are traveling the entire colon. And you can see that when it's green, we are in around the range of pressure that is like 70 millimeter of mercury. So these are called low amplitude propagating contraction that are traveling the entire colon. So this means that both the osmotic laxative and the secretagogue linaclotide are inducing this kind of long contraction of low amplitude. And this is what we observe with this. Next slide. When you administer prucalopride, that is a prokinetic, I was expecting to see some activity that was a kind of contraction, propagating contraction. But by my surprise, what I observe is this kind of repetitive activity in the colon that is simultaneous activity that is happening in the entire colon. And you can see from the right until the rectum, and still again, low amplitude activity. But then, when I studied, next slide, bizacodil, you can see that the response is completely different. In this case, we have the so-called high amplitude propagating contraction, that are those contractions that we know from the literature are those that normally precede the defecation process. So these are the contractions that we have normally in our normal life before we go to the toilet, and we have the stimulus to go to the toilet. So you can see that four different drugs have a completely different response of the colon. And this was something really interesting, because before, when we were really thinking about using this medication, and when the one single medication was not working, we were thinking about combining this medication, and we were thinking, okay, let's combine an osmotic laxative with a stimulant laxative, because this makes sense. One increase the water content in the bowel, the other one stimulate the motility. Now, after this evaluation, I realized myself that is also interesting the possibility to combine prokinetics like prucalopride that probably just make our colon more tonic and more reactive, and prepare the colon to the stimulus of another drug like the stimulant laxative bizacodil. And so I combine this medication in my clinical practice in those patients that are not responding to the single one. Next slide. This is when I did this study, I actually realized myself that we are using a lot in clinical practice drugs that have been developed more than 30 years ago and we are using in the clinical practice, sometimes we don't realize that we don't know exactly how to use this medication in clinical practice. So this was an interesting exercise that I done with the team of Sanofi, and we actually reviewed the literature about Bisacodyl to really remind ourselves and really see whether there are some information that we need to take in consideration when we use this medication in clinical practice. And I found something that indeed is interesting and is important to remember. Next slide. So Bisacodyl and picosulfate, for example, are both stimulant laxative, and they are both metabolized to the same metabolite that is the one that is responsible for the activity in the colon. But what is different and is important to take in mind is that sodium picosulfate is metabolized by the colonic bacteria and to reach the same metabolite, while Bisacodyl is metabolized by the gut mucosa. This means that if you have a patient that is not responding to Bisacodyl, you can think about using picosulfate, because it's possible that through the different mechanisms, the patient will respond to one medication, not to the other. It's also important to consider, and this there is only an animal study that has reported this information, but has been shown in animals that the intake of antibiotics can, of course, affect the function of sodium picosulfate, because if you change the bacteria in your colon, you can really modify the bacteria that are metabolizing picosulfate. So the other way around, if you have a patient, it happened to me last year that I had a patient that was admitted and was under antibiotics. I was treating the patient with sodium picosulfate, and this was not acting in this specific patient. I switched to Bisacodyl and I had the response, and this is something to keep in mind when you have in your clinical practice the patient. So they are the same medication, they have the same metabolite, but to be active, they have two different kind of metabolization, and this is something that you can think in your clinical practice. Next slide. Why Bisacodyl is probably an interesting molecule in clinical practice is because is one of the few molecules that act both on motility and secretion, so improve the secretion and the motility in the colon. And this is now we are running a study with the MRI to actually demonstrate and see what this drug is actually doing in vivo in humans after you take the medication by mouth, because it seems to be strange, but we are using these medications in more than 30 years, but still we don't have the proof of what is happening inside our gut, and this will be for the first time clear with the MRI, with the study that we are doing here in Nottingham. Next slide. So Bisacodyl, like other, as I reported before, picosulfate and also SEDA, is more effective than placebo in treating chronic constipation, and this has been studied in this study in 2010. There was the first very well conducted study, placebo-controlled trial with a laxative that is available in the market, and you can see that the response is quite fast in the first week, and then is maintained until 4 weeks. But the concern sometimes with in clinical practice is that this medication sometimes can induce some abdominal pain, because of course stimulating the colon, this can trigger some abdominal pain. And thanks to this review, I realized myself that I was using in a wrong way this medication in clinical practice, because next slide. I didn't realize myself that in this trial, yes, the medication was effective, more effective than placebo, and there were a report of more abdominal pain and diarrhea in this patient. But what I didn't realize is that in this study, the medication was started at 10 milligrams, so 2 tablets from the beginning, and then the patient was allowed to adjust the dosage and really reduce the dosage or maintain the same dosage according to the response. And as you can see here, a lot of patients actually reduce the dosage of Bisacodyl to 1 tablet per day instead of 2 per day, and this associated with the reduction in the presence of side effects. So this really taught me that in clinical practice, instead of starting with a high dose, and so with 10 milligrams, you need to start with one tablet and then adjust to the response of the patient. But this is something that I didn't realize myself until I reviewed the literature and interact really with the team of Sanofi that really make me realizing this kind of difference that I didn't realize before. Next slide. So after I saw these results, as I said before, these results can also help us, guide us to really decide how to combine the different medication. And as I said now, I'm using, according to the guideline that I just show you, the different medication. But if they don't respond to a single medication, then I start combining, but not only osmotic laxative and stimulant laxative as I was doing before, but now also stimulant laxative with prokinetics, because I showed that they have two different mechanisms of action at the level of the colon. Next slide. They asked me to speak also about occasional constipation or temporary constipation, and I have to say that there is now an interest at the international level, because it seems to be strange, but we still don't have an internationally recognized definition of occasional constipation, and now we are working on this because it's quite important. Yes, we have a lot of patients that have chronic constipation, but we have also patients that have occasional constipation, so this kind of infrequent and irregular episode of constipation, and we need to also develop guidelines for this patient, have studies that are randomized and controlled to treat also this patient, and from what we know from the literature, the same drug that we are using for chronic constipation are likely to be the same effective indeed in occasional constipation. But this is a chapter that we are going to develop, and I'm part now of an international group of experts that are dealing really with this definition and with the treatment of this patient that are, of course, quite prevalent in our population, and we need to also have some questions, some answers for them. And with this, I thank you for your attention. Next slide, and I'm happy to answer any question. Thank you.
Thank you very much, Dr. Mara Corsetti, for this interesting presentation, also on this more molecular or medicine aspect of and I'll have some questions afterwards, because also from the experience of community pharmacists, I think there might be some community pharmacists in the audience. Also, this relationship with the laxatives, and especially the elder, they come to the pharmacy a lot, and how can we better manage or support them? But I'll leave those to the end. Thank you very much.
Yeah.
For the next presentation, we have Dr. Joanna Harnett. She holds a Bachelor and Master of Health Science, Complementary Medicine. She completed her PhD in 2013 in the field of nutritional pharmacology, exploration between the gastrointestinal microbiome and celiac disease. Joanna is a senior lecturer of Medicine and Health at the University of Sydney's Pharmacy School, and she will bring to us the practical tips for pharmacists on providing nutrition advice to improve digestive wellness. Thank you very much, Dr. Joanna Harnett, and I'll give you now the floor.
Thank you very much, Ruben, for your introduction, and thank you so much to Maura and also Anya for your really interesting presentations from the views of a pharmacist and also the views of a gastroenterologist. So my presentation is in response to a request to talk about some practical tips for pharmacists on providing nutrition advice to improve digestive wellness. So wellness, as many of us may know, is the active process through which people become aware of and can make choices towards a more successful existence. And this includes the area of nutrition and making informed decisions about what we eat and being conscious of how those decisions can impact our health. And it's very fitting as we have our World Gastroenterology Week with a focus on the prevention of colorectal cancer that we have this webinar today. So whilst the role of pharmacists is clearly as medicine specialists and treating disease with pharmacological means and preventing complications with pharmacological means, there is clearly also a role for providing strategies to improve the general nutrition of the public. And this is not to replace clearly the role of expert nutritionists and dietitians, which, as Anya mentioned earlier in her presentation, play a critical role in dealing with some of the complexities around the digestive illnesses that someone may experience across their lifespan. I'd like to draw your attention, if you're not already aware of, the nutrition and weight management services, a toolkit for pharmacists that has been published by the FIP, which is an excellent overview of nutrition within the context of the profession of pharmacy. So the relationship between nutrition and digestion is indeed bidirectional. And by that, I mean, what we eat and drink impacts our digestive health, but also our digestive health can impact how we process and absorb the foods that we eat. And there are multiple organs that are involved in that process, as Anya presented in the first lecture of today's series. The importance of the oral health, I think, is very undermined in nutrition health, and being able to advise people to ensure their oral health is checked by the appropriate dental expert in that area. And the oral microbiome, we're becoming much more aware of the role of the oral microbiome in digestive health as well. And likewise, these other organs, as I mentioned here. So digestive wellness starts early, and I think the majority of people listening will be well aware of the World Health Organization's messaging around the importance of breastfeeding our young infants, regardless of the country in which we reside. So we know that breastfeeding reduces the risk of diarrhea in infants below 2 years of age. And we know that suboptimal breastfeeding is responsible for 30% of diarrheal deaths in children under 5 globally. So WHO encourage exclusive breastfeeding for the first 6 months of life, in addition to solids during the first 2 years of life. I'd also like to add that the first 3 years of our life, from the time we are born, and in fact some argue from in utero, is the development of the gastrointestinal microbiome. So as a baby is born into this world, it is inoculated through the vaginal or the skin microbiome, depending on how that child is born. And then the breastfeeding practices set up that microbiome, and what is set in that first 3 years of life is what we basically take for the rest of our life, or our set microbiome, with transient changes depending on our different environmental and dietary practices and medicine practices. So the role of breastfeeding in setting up a healthy microbiome and therefore ability to digest and absorb foods well starts very early in life. So pharmacists can promote the benefits of breastfeeding practices, and being aware of who the specialists or the community nurses are in your area for when women perhaps are having difficulties with being able to breastfeed their infant. So fruit and vegetables, it sounds like a very noble intervention that can be applied worldwide. And this is a very, very true for our digestive wellness. So we know that increasing an individual's fruit and vegetable consumption to a minimum of 4 grams a day could reduce the total worldwide burden of disease by 1.8%. So this is very substantial. And we know that insufficient intake of fruit and vegetables is estimated to cause around 14% of gastrointestinal cancer deaths per year, including of the stomach, the esophagus, and also of the colorectal area. So a very simple intervention of increasing fruit and vegetables could result in seeing a decrease in some of these conditions. So it's very easy for pharmacists to promote awareness about the importance of fruit and vegetables and giving some guidance around 400 grams, which is equivalent to around 5 portions of vegetables per day. But this should not count starchy vegetables such as potatoes, sweet potatoes, cassava, and other starchy roots. So what does a serve look like? It's actually not as big as one might think. So generally half to a cup of vegetables, and for fruit, either 2 small pieces or 1 medium piece would be equivalent to 1 serve. So some of these very simple pieces of information for a person is something that you're caring for, is something they can carry into their day-to-day life and implement clearly, dependent on the availability of produce in their area. Something that has gathered worldwide attention, particularly in the prevention of gastrointestinal cancers, is the role of red and processed meats. So here in Australia, where I'm speaking from today, 1 in 6 bowel cancers is associated with the overconsumption of red or processed meats. And as you can see from this figure, the Cancer Council here recommends eating no more than 700 grams, which is around 7 100-gram servings. And red meat refers to beef, lamb, and pork. And the recommendation is where red meat is eaten, that the portions are of this size and that they are lean. So the fat is cut off them. And trying to eat at least 1 or 2 fish meals a week to substitute red meat, and also consider the use of different poultry as well. So for many developed countries where red meat is eaten in excess, you can see portion sizes here are actually much smaller than what you might see in some of the restaurant servings around our globe. So it's also important for people to be aware of the association between cancer risk and processed meats. So by processed meats, we mean salamis, hams, sausages, and it's due to the smoking or the curing and salting of these processed meats, and also they're notoriously high in fats, that there is this link to bowel cancer has been made. There's also nitrates that are used in the preservation of meats, which have been linked with carcinogenic mechanisms as well. So limiting the amount of these products is important if there are other protein foods that can be substituted within the region that you live. And these lovely figures have been taken from the Cancer Council in New South Wales, Australia, to help illustrate this message to you today. So pharmacists can promote messaging around limiting red and processed meat, especially where there are alternative proteins for people to consume. So we've heard a lot about the benefits of fish, or more specifically, omega-3 fatty acids, particularly in the area of cardiovascular disease. But there is some limited evidence, whilst not strong, to suggest that eating more fish may protect against liver and bowel cancers as well. So there are some caveats here and important considerations, and that is the consumption of Cantonese-style salted fish may increase the risk of nasopharyngeal cancer. And there is also strong evidence that consuming foods preserved by salting, which includes dried fishes traditionally prepared in some Southeast Asian areas, can actually increase the risk of stomach cancer. So limiting the amounts of these foods is important. So tips for pharmacists to be able to pass on to the people they care for is encouraging people to eat fish at least twice a week and avoiding the salted or dried fish forms of that food. The oily fish is the ones that we would like people to eat. And also being aware that some fish may contain heavy metals, depending on where they have been fished. So mercury and lead and aluminium may be present. And most fishing authorities within the region that you live will have lists of fish that should be avoided for that reason. So probiotics, Maura touched on them in her presentation on constipation. So what are they? They are live microorganisms that, when administered in adequate amounts, can confer a health benefit to the host. And they're obtained through specific foods that we may eat, foods that have been fermented or foods that have cultures added to them for their manufacturing. And also over the last decade, also in supplements. There is no recommended daily intake for the amount of probiotic bacteria or yeast that we should consume, nor are there safe upper limits that have been established to date. And the colony forming units per gram, which is the way in which these bacteria or yeasts are measured, vary greatly, both within foods and between foods. They're more well defined in supplements. So an important consideration around probiotics is around their taxonomical ranking. So you will have the genus, the species, and the strain. So for example, Lactobacillus is the genus, Rhamnosus is the species, and GG is the strain. And why this is relevant is due to the more general and then the more specific actions of probiotics. So I'd just like to talk you through this slide here that I have taken from the paper cited on the bottom of this slide. So there are, in the blue section here, we have widespread activities that have been attributed or identified to a broader number of probiotic genuses. So this involves colonization resistance to pathogenic bacteria, the production of setting up a more acidic pH, and the production of short-chain fatty acids. Now, these short-chain fatty acids play a very important role in the health of the intestinal epithelium. They also may play a role in the regulation of intestinal transit, the normalization of a perturbed microbiota, for example, after the administration of antibiotics that have perturbed the microbiota of the individual, and play a role in competitive exclusion of pathogens by competing for its sites on the epithelium of the GI tract. Once we come up to the species, so remember genus, species, strain, when we're looking at the species level, we start to see some more specific activities that have been identified. And these involve the synthesis of different vitamins by the bacteria in the intestine, direct antagonism, bile salt metabolism, enzymatic activity, for example, the production of lactase to help break down lactose from milk products, and the neutralization of carcinogens. In terms of very specific pharmacological effects, these have been associated with very specific strains, and this is more rare, and this is an area of research that is exploding at the moment, is trying to understand what strain-specific bacteria may play a role in neurology, immunology, endocrinology, and the production of specific bioactives. So the take-home message from this slide is that we need to be aware, particularly as it relates to probiotic supplements, that there are widespread applications, there are more specific applications, and there are rare applications. And there is a need for evidence-based approach to the application of these probiotic species in day-to-day practice. So as I mentioned, there are a range of genus, and one of the most common is that of the Lactobacillus. And as you can see, there is a number here, a number of species that are commonly found in many of the foods that we eat. Likewise, Bifidobacterium, there are a number of species that are also identified in a number of the foods we eat. And Streptococcus thermophilus, which is a common starting bacteria for a number of the dairy products that are produced across the world. So what are these probiotic foods? Yogurt is probably the most palatable and well-known of probiotic-containing foods, as is kefir and some of the aged cheeses. So these are predominantly made from milk products, but more recently, these are also being made from other products as well, such as coconut and other protein sources for people with a preference to avoid animal products in their diet. They can also be found in sauerkraut, which is a form of fermented cabbage, which is more prevalent amongst European countries, and also kimchi within Southeast Asian countries. In terms of soy, miso, a fermented soy product, and tempeh, another fermented soy product, and also sourdough bread. Interesting, the sourdough bread, or the fermentation process used in the production of sourdough bread, which is one of the Lactobacillus bacteria, helped to degrade the actual hardiness of some of the proteins in that bread, making it more digestible for some people with intolerances. So the tip for pharmacists is that you can promote the inclusion of foods that contain probiotics to support digestive health more generally. But more specific areas or claims for specific conditions, I encourage you to follow this link in the National Institute of Health, which gives a nice summary of some of the evidence around specific use for specific species and strains, as I mentioned on the previous slide. So lastly, I'd like to talk about prebiotics. So prebiotics are like the food or the soil for the probiotic bacteria to grow. And these are largely defined as selectively stimulating the growth of beneficial bacteria with that have a favorable metabolomic profile in the gastrointestinal tract. So some prebiotics, such as inulin-type fructans, fructooligosaccharides, and lactulose, which many of you will be familiar with as a form of a laxative and used in other pharmacological interventions, they have been shown to increase the health-promoting colonies of both the genre Lactobacilli and Bifidobacteria, which I spoke of earlier. So prebiotic foods occur naturally in many fruits and vegetables and algae that people consume across the world. And in fact, an estimated 36,000 plants contain fructooligosaccharides. So FOS, which is fructooligosaccharides, and other fructans are found in low concentrations in many common foods that are consumed, and they're outlined here. So the tip for pharmacists is that many plant-based or plant foods of plant origin will be naturally high in these prebiotics. And it's perhaps this is one of the mechanisms by which they may exert a beneficial effect in preventing many of the non-communicable diseases that are currently very prevalent across our globe, particularly in more developed and westernized countries. So in summary, pharmacists have a very important role to play in promoting very simple dietary practices that support digestive health across the lifespan through the promotion of breastfeeding, increasing fruit and vegetable intake, limiting red meat and processed meats in areas where it's feasible to do so, the inclusion of omega-3 fatty acids through fish meals, but you can also obtain omega-3 fatty acids through some plant sources such as flax seeds, and walnuts and some other nuts and seeds, and also the inclusion of probiotic and prebiotic containing foods, and engaging with public health nutrition initiatives in your region, and also with nutrition experts in your region as part of the healthcare teams and systems in which you engage. So again, I'd like to thank FIP for the opportunity to share this summary, particularly during this very important week around global health and digestive health.
Thank you very much, Dr. Joanna Harnett. It was very interesting to see this broad set of messages that pharmacists can consider when talking to the patients in the community pharmacy. We'll have now some time for questions. I'll invite the other panelists also to join. And I think we'll start with a quick question for each of you for a brief comment. And then we'll open to more general questions, and I'll invite the panel to join. So I'll start with a very question about on your slides you had, for example, that in the future the metabolic syndrome could be a problem, for example, and then also the recurrent dyspepsia. I saw the mentioning test. So my question is, what do you think for the pharmacists listening to this webinar? Think could be in the future the main problems related to digestive health, the main bullets, of course, and if there are any tools like this test that they can use to assess if there's a need for referral or not.
I mean, for the metabolic syndrome, the best thing is to lose weight, and Dr. Harnett has really shown that nutrition is absolutely essential. I know from liver disease, fatty liver, if you lose 10% of your weight, you restore 80% of your liver problems. So, you know, losing weight with metabolic syndrome is the best, but it's really hard and it needs a multidisciplinary approach. And, you know, nutrition is just, well, that's what we live on, isn't it? And if we don't look after it, it just ends up with all sorts of problems like cancer, like liver disease, heart problems.
Thank you. On the call, there's this question also on the guidelines for the PPIs or H2 antagonists on the question box. Maybe you want to provide a comment?
Yes, there is a really good, the NICE guidelines are very good on dyspepsia. And if anybody works in primary care, in the UK, we have Guidelines in Practice, which is a journal which is open, free for GPs, and they have an excellent flow charts on how to manage dyspepsia. And that includes, if you go to CKS, which is the Clinical Knowledge Share, which is nice. There is a lot around non-steroidals, how to manage them and how to avoid. So there's lots and lots of information around. I'm sure the same in most countries will have guidelines.
Perfect. Thank you so much. This also covers the following question also on the NSAID. Some resources on the NICE website could be found there. Thank you so much. I'll jump to Dr. Maura Corsetti. And the question that I have is what when you ended your presentation that here is a bit also on the long-term use of these laxatives, because that's, I think it's very common in the community to find elders that have a long history of laxatives. So my question is a bit, or a comment on how can pharmacists better manage this, or when they also should refer these patients.
So let's take in mind that most of the study conducted, the placebo-controlled studies, have been conducted in the short term. But we have a lot of post-marketing data on the use of this stimulant laxative. And now I have to say that we don't have concern for the long-term use of this medication. Of course, as for any medication, you need to take this if they are necessary at the lowest dosage. And of course, your GP needs to be aware of what you are taking and not really decide yourself what is safe for you to take and to use with this medication. My experience tells me that also we have some kind of misconception about what is constipation in the community. Sometimes people think that if they don't open the bowel every day, this means that they have constipation. This is not true. We know that a normal person, an healthy person, and especially a female, is perfectly normal if you open the bowel 2-3 times a week. So we need to also educate our patient to really don't be obsessed, especially with the elderly patients. Sometimes this is the case, that of course they really want to open the bowel at a certain moment. They need to want to open the bowel every day. So this enter in a vicious circle that they take more medication, they increase the dosage, pretending to have something that is actually not healthy for their life.
Thank you so much. I think that's an interesting point also to consider the natural rhythm of the human body.
Yeah.
Perfect. Thank you.
Can I add to that, Ruben? I'd just like to add to that, because I think it's a perfect space for nutrition too. I'm sure Maura and Anya would agree that, you know, in most countries, when you look at guidelines for treating constipation, it's around encouraging and increasing fruit and vegetable intake and fiber intake, fluid intake, and getting people to move and exercise. And those things in and of itself can be quite effective in helping people get to that natural rhythm, as Maura explained.
Yeah, and it's also important to remember that now we have also a lot of an increasing number of studies demonstrating the effect of, for example, fruit like like kiwi, like prunes. Now we have really evidence behind what has been used for ages to improve constipation. Now we have really the evidence from clinical trials and also from study with MRI, really demonstrating what is actually happening inside our colon with this kind of fruit. So now we can really be more confident in suggesting this kind of tips to the patient that before was just kind of, common knowledge, but without so many evidence behind.
And I think that pharmacists, particularly in community, are ideally placed to diagnose laxative abuse.
Yeah,
it's widely spread, and we need to address it, because the long-term problems that come from laxative abuse are very expensive to the health system.
Indeed. Thank you so much. I'll just go for the quick question, and then I'll open the floor again for another discussion. Joanna, you presented a lot of messages and a lot of ideas, important tips. But then when it comes to put them in practice, there might be time barriers or some difficulties in putting them into practice. So do you have maybe any strategies, either being, I don't know, social media or flyers in the pharmacy? So how can we digest, so to say, this information and make them available for the patients in the pharmacies?
Yeah, you're quite right, Ruben. If you look at the evidence around pharmacists and the medical profession more generally being able to take the time to provide nutrition advice, the factor of time being time poor is a significant barrier. So I think what I was trying to say, and I may not have done it successfully, is just simply when a pharmacist is handing over a prescription and saying, don't forget it's really important to eat 5 serves of veggies a day. Or if someone's coming in with, really with anything, saying don't forget your nutrition plays a really important role. The FIP Nutrition Toolkit has some really fabulous resources there. But also, there are other websites and resources that patients can be referred to within their country. I know in Australia we have the National Health and Medical Research Council, and they have dietary guidelines for Australians. And I know in the UK, you also have the NHS have dietary guidelines. So I'm sure there are in the NIH in the US, and I'm sure there are in other countries as well. So even directing patients to evidence-based resources can be something that can be done. But again, just simply saying, don't forget to eat your fruit and veggies, have some fish this week. Those little things that just might stay in people's minds.
Perfect. So just keeping that in mind, and at the time that the opportunity comes, just go for it. Perfect. Now that I have 2 pharmacists and a medical doctor, I also want to bring up a last point of discussion, which is the interprofessional collaboration. So now for the 3 of you, for the panel, some quick comments on maybe some areas where this collaboration could be more important, or some ideas, strategies that you also have. And I'll maybe start with Anya again.
Okay, for me, it's the most important thing that you get really to professionally know your multidisciplinary team. So if as a community pharmacy, make sure you know your local chemist, your local GP practices. In the UK, we're now lucky we have pharmacists in the GP practices. And I look at my role really as a translator. I translate the GP's language into either commissioning language or into patient language. We are really good at explaining, and that's what we need to do. And we need to make sure that we are in line with what the prescriber is doing. And in the hospital, just be part of the multidisciplinary team. You're bringing so much to that team. Yes, the medics can do pharmacology, but actually we're the specialists and we get into the details, which often gets missed when in the whole diagnosis of therapies.
Perfect. Maura, you want?
Yes, I think that this is a very important point, and I have to say that because I worked in different countries, I worked in Italy, I worked in Belgium, and now in UK. Of course, UK is a unique environment where there is indeed this collaboration between pharmacists and clinicians. I have to say that this is not the case in every country. So I think that this is very important because I learned myself how this interaction can improve then the treatment for the patient. And sometimes it's not infrequent that pharmacists remind us, Dr. Cossetti, you wrote this, take in mind the interaction or something with this drug, because we know this, but of course, sometimes we are in a busy clinic and this kind of check between the 2 different expertise is quite important. Also for medication that are considered some not that are considered safe, also for laxative or for other medication that we normally prescribe without even thinking so much about what we are doing. We need to be honest. And the same is, for example, for the big issue that we have here in UK for the use of opioids that is so diffuse, and this is really impacting so much on the gut function. And I see a lot of patients that have a constipation because then they are taking this medication without even knowing that even codeine can affect quite a lot the entire GI tract. So that's why I think this kind of collaboration should be really improved in every country. And I think that probably we can take some example from UK in this case. I think for this interaction is something that I found quite unique, I have to say.
Perfect. Joanna, you want to comment on this one?
Yes, so just to be clear, I'm not a pharmacist. I am a pharmacy educator specializing in nutrition and the complementary medicines. And so I just think adding to what Anya and Maura have said, one of the pieces of work I've been involved in is around interprofessional communication around the over-the-counter medicines such as herbal preparations and supplements that people might use to treat gastrointestinal disorders, and being very aware and the importance of understanding potential interactions. Pharmacists have brilliant knowledge of pharmacokinetics and pharmacodynamics, and are really well placed to even make theoretical considerations around potential interactions between the things that people may have bought and that they don't disclose. So disclosure of complementary traditional medicines, dietary supplements, whatever they're called in the respective regions, is typically very low because individuals don't think they're relevant to their mainstream or conventional healthcare that they receive. So this is a really great place for pharmacists to engage in asking, are you taking those things, and being able to identify if there's any interactions.
Perfect, thank you.
One more point about pharmacists can be antimicrobial guardians. You know, we don't need antibiotics as often as we use, particularly for diarrhea. And I'm sure Joanna is very keen because it kills your bacteria and you have to restore it afterwards again. And you know, we need to be much more careful with how we use, particularly travel diarrhea. You know, antibiotics are not necessary most of the time.
Thank you so much for this. I know we could be here discussing these topics for longer, but for the sake of time, we need to get into the closing. I think it was a very interesting session. Before I go into the last announcement, I would just like for you to give a 30-second key message so we can close. So Joanna, I'll start with you.
The gut is the epicenter of our health, and what we feed it plays a really important role for our present and also our future.
Perfect. Thank you. Maura?
Well, I would just conclude saying that constipation is an important problem. Don't underestimate this and use the medication in the appropriate way to get rid of this.
Perfect. Anya?
For me, is be ambitious in your career, develop your whichever specialty you want to do. And there are frameworks. The FIP has fantastic frameworks to develop anybody into an advanced practitioner wherever you like to be.
Perfect. Thank you so much. So now moving on to the closing remarks, just a small wrap up. So we heard the different blocks in this presentation, and there's 3 more events on this. We'll explore also more aspects in each of these areas. And check the FIP events website that I'll check later. A general idea or a 30-second from my part is just that there are pharmacists in digestive health, and there is probably a need for more training and more involvement in this area. And so there are resources, as Joanna said, there are websites, and there are already tools. So the offer is need to grab them and as Anya said as well, you need to be advanced but generalist on this area, because we need more pharma in this area. Just a few announcements before closure. There's the FIP Pharmacy Practice Research Summer Meeting, 4th to 5th of July, Netherlands. This is meant for PhD students, postdoctoral fellows, and other academics. So you can check the deadline is until the end of June. It's quite an interesting meeting, more focused on the academic side, of course. Different areas of pharmacy practice can be shown here, especially if you have also some works on the digestive health, you can submit your abstracts. Then in Seville, in Spain, on the month of September, there's the World Congress, the FIP. The topic is Pharmacy United in Recovering of, and you can see the different topics. Of course, now due to the pandemic, this is a focus, but there are also side events and other events that are available. You can submit your extra also until, and then the announcement will be in July. Again, we'll have next event on the 7th of June, so you can check it on the events.fip.org. we'll focus a lot also more also on constipation and diarrhea and in specific areas further. And during the month on the 16th and the 21st, there's also a couple more events focusing on inflammatory diseases, and then also a bit of on probiotics and immunity. So there's a lot of areas that we can focus on digestive health and wellness. Thank you very much, everyone, for joining this webinar. Thank you for all amazing speakers. The recording will be available on the events website if you need to go through any references or any ideas. And if you have any questions, you can also send an email to FIP and we'll put you in contact. So thank you very much. Have a great day or evening, depending where you are, and more FIP events.
Thank you.
Thank you.